Hello and welcome to the first webinar in our 2022 series. Today's webinar is called Celiac Disease and Your Reproductive Health, hosted by the National Celiac Association and the Celiac Research Program at Harvard Medical School. I'm Lee Graham, Executive Director of the National Celiac Association, serving the gluten-free community since 1993. Thanks to all of you who have donated to our food insecurity initiative, Feeding Gluten-Free. From the bottom of my heart, many, many thanks to all of you who've supported this initiative. Together, we've been able to do so much. For today, you are welcome to ask general questions through the Q&A feature, which is located on the bottom right corner of your Zoom screen. If you're still struggling to connect with us, tech support is available if needed at digitalmedia@partners.org or phone 857-282-6470. Also, this session is being recorded and will be available for viewing on NCA's website, nationalceliac.org. I'm honored to introduce our moderator today, Dr. Dasha Weir. Dr. Weir first became interested in celiac disease during her medical training and is now a board-certified pediatric gastroenterologist with expertise in celiac disease in children. She is the clinical director of the Celiac Disease Program at Boston Children's Hospital and serves as the medical advisor of the Celiac Kids Connection. Originally a Boston area native, she attended Dartmouth College and graduated with a BA in history in 1995. She subsequently graduated from Case Western School of Medicine in 2000 and returned to Boston to complete her internship and residency in pediatrics at Boston Children's Hospital and Boston Medical Center. After finishing her pediatric gastroenterology fellowship at Boston Children's Hospital, she joined their division of gastroenterology there and nutrition and is involved both in clinical care and celiac-related clinical research. She is also on the executive committee of the Harvard Medical School of Celiac Research. Welcome, Dr. Weir.
Thank you so much, Lee, and thank you to the NCA for this fabulous series and for specifically including me in today's session. We have two speakers today, Dr. Marcela Banegas and Dr. Maureen Leonard, who I'll tell you a little bit more about later. And we also have Amelie Therrien, who will be joining our panel for the question and answer portion at the end. So I'm now going to invite Dr. Banegas to share her screen as I introduce her. Dr. Marcela Banegas is a Honduran physician who obtained her medical degree from one of the top medical schools in Latin America, Tecnológico de Monterrey in Mexico. In 2019, she was accepted to the International Research Initiative Program, where she joined a team of passionate students who have graduated top of their class to pursue their interests in research at Harvard-affiliated hospitals. Marcela has a strong interest in immune-mediated gastrointestinal diseases such as celiac disease and hopes to keep expanding her knowledge and research in celiac disease. She recently joined the research team at the Celiac Center at the Beth Israel Deaconess Medical Center and HMS Celiac Research Program as a clinical research fellow. Her current research investigates frequency of symptoms in patients undergoing a gluten challenge, clinical manifestations of celiac disease during the postpartum period, and personal involvement of celiac disease researchers with celiac disease. Welcome.
Thank you so much, Dasha, for the introduction. It's a pleasure to be here. So today we're going to talk more about celiac disease and reproductive health. Before I go on, we can start with the question we have on poll right now. So let's start off. What is your main pregnancy-related concern as it relates to your baby's health? So the following options would be still having inflammation at the time of the pregnancy, that my baby will develop celiac disease, having inadequate nutrition, getting glutened, or no concerns. So we're going to revisit the responses in a few slides ahead, but go ahead and pick your choice. So some disclosures for this presentation. Dr. Amelie Therrien is site PI for immunogenics, and I do not have any conflict of interests. So today we're gonna talk more about, we're gonna discuss the risks of untreated celiac disease in pregnant women and their fetus. And we're gonna talk more about women with established celiac disease as well on a gluten-free diet. We're gonna review that celiac disease can present during pregnancy and postpartum. And we're gonna talk more about symptom flares of celiac disease during the postpartum period. At the end, we're going to go through some keys to support a healthy pregnancy as well. So I'm just going to give it a couple of minutes to have the voters do their poll question. But let's start off with the first topic. What are the risks associated with undiagnosed celiac disease during pregnancy? So silent or undiagnosed celiac disease has been associated with gynecologic and obstetrical complications, such as infertility, spontaneous abortion, preterm labor, intrauterine growth retardation, and low birth weight. There was a well-known association between unexplained infertility and celiac disease. Actually, previous literature shows a prevalence of celiac disease of 4% to 10% among women with unexplained infertility. However, the most recent data we have had is that in a meta-analysis, including studies up to 2019, they did not show an increased rate of celiac disease among women with unexplained infertility. So what does this mean? Basically, this may signal that we are getting better at diagnosing celiac disease earlier. However, we would still recommend doing TTG as part of the workup for infertility. The TTG are the celiac antibodies. Some adverse pregnancy outcomes associated to untreated celiac disease are the ones mentioned here. For example, spontaneous miscarriage, intrauterine growth restriction, preterm delivery, low birth weight, stillbirth, and having a fetus small for gestational age. What do I mean by saying relative risk? This is when we compare it to the general population. In this case, for example, let's take stillbirth. Stillbirth has an incidence of 1 of 160 births in the US. However, for women with untreated celiac disease, this risk increases by four times. So this would mean that this patient would have an incidence of 4 out of 160 births compared to the general population. There may also be a small increased risk of birth defect if the mother has undiagnosed celiac disease. Especially, we've noted defects associated to heart and urinary defects. However, one thing to keep in mind is that these defects are not uncommon in the general population. And regarding heart and urinary defects associated with undiagnosed celiac disease, these don't tend to be life-threatening. So let's move on. Well, before I move on to the upcoming topics, I would like to go back to the responses we had from our poll. Okay, excellent. So let's see. According to the responses, again, the question was, what is your main pregnancy-related concern as it relates to your baby's health? The number one voted response was having inadequate nutrition, followed by that my baby will develop celiac disease. And the third most voted choice would be still having inflammation at the time of the pregnancy. And finally, getting glutened was the final choice. So it was very interesting seeing that having inadequate nutrition would be the most voted choice. Okay, so we're gonna get into that briefly. So how is celiac disease associated with all of these reproductive disorders? We're not going to go very into deep with all the molecular stuff, but giving you just a brief perspective of what's going on in the body. Well, the suspected mechanisms of celiac disease in pregnancy is that celiac disease may lead to malabsorption, which may lead to nutritional deficiencies. Nutritional deficiencies play an important role, especially because they have a risk in potentially altering the hormonal axis. And also, this may have a risk on having a less deficient, a less nutritional overall state on the fetus. Also, there's an increased intestinal permeability, increased risk. So in the intestines, we have cells connecting each other by tiny molecules. In celiac disease, these molecules can be kind of loose, letting some toxins into the body and into the circulation, and potentially increasing inflammation overall. So a place where can induce inflammation would be the uterus, for example. Also, the circulating antibodies would lead to an impaired placental function, causing mainly damage to the placental vessels and also having an effect on the nutritional status of the fetus. So let's move on to what about men? So let's talk more about celiac disease in men and their reproductive health. There have been previous studies showing that there have been reported hormonal imbalances, also alterations in spermatozoid morphology and motility, and reduced libido. However, in these previous studies, they also showed that these outcomes would improve on a gluten-free diet. However, more recent studies have failed to show this association. They show that there was no difference between number of offspring from men with celiac disease versus the general population. And also, there was no increased risk of congenital malformations. So, how can I reduce all of these risks? Well, definitely your favorite ally should be the gluten-free diet. A large cohort study showed that undiagnosed celiac disease was associated with the following adverse outcomes. For example, increased risk of intrauterine growth retardation, preterm birth, or cesarean C-section. However, a diagnosis of celiac disease made before the pregnancy was not associated with these adverse fetal outcomes. So, are there risks if my intestines are not completely healed when I am pregnant? It is important to maximize absorption and avoid deficiency, especially in iron, calcium, zinc, magnesium, folic acid, vitamin D, and B vitamins. A study from 2015 by the Celiac Center at Columbia and collaboration with researchers in Sweden collected data on 337 women with celiac disease who gave birth within 5 years of a follow-up biopsy. So what did they find? They found that there was no increased risk of intrauterine growth retardation, low birth weight, preterm birth, and C-section in women who still had villus atrophy on their biopsies versus women who had normal biopsies. However, it is very important to mention that these women were also on a gluten-free diet, and they hadn't completely healed yet from their intestines. Talking more about pregnancy and celiac disease, is there a period of my pregnancy where I might be more susceptible to present with celiac disease? Well, first off, luckily, there is usually a period of immune tolerance in the first 2 trimesters. However, in the 3rd trimester, there may be some hormonal fluctuations which may lead to a shift of the immune system and final loss of tolerance to gluten, inducing more inflammation. So then we can see more symptoms like diarrhea, weight loss, dehydration, and also it can lead to hospitalization. How do we make the diagnosis of celiac disease during pregnancy? Well, the first diagnostic step for celiac disease during pregnancy would be celiac serologies. Upper endoscopy is usually avoided during pregnancy, but is recommended afterwards. Also, systematic screening among pregnant women is not recommended unless there are other reasons to screen. For example, if the patients come in with some symptoms, diarrhea, abdominal pain, etc., or if they have any other family history related to celiac disease or other autoimmune disorders. Celiac disease presentation is also frequent during the postpartum period. So, in a brief literature search, we found out that the majority of the women who presented with celiac disease in the postpartum period was mostly during the first pregnancy. They also had a classical presentation. What do I mean by classical presentation? Is that the patients come in with the typical symptoms for celiac disease, for example, diarrhea, abdominal pain, bloating. And these patients also showed having a history of GI symptoms in the childhood or before pregnancy. And interestingly, all had a good response to a gluten-free diet. In a cohort study of 186 women with celiac disease, they found 20% associated pregnancy as a stressful life event associated with their celiac disease diagnosis. So, what happens in the postpartum period among women with established celiac disease? Unfortunately, we do not have much information about established celiac disease in postpartum. A retrospective chart review at our institution found that 10% of women with established celiac disease reported symptoms during the postpartum. Then again, in a national survey, we sent out a survey to the subscribers of the mailing list of the Celiac Disease Foundation from December 2020 to January 2021. And we found that 45% of the eligible subjects experienced symptoms during the postpartum, which they all attributed to celiac disease. What else did we find? We found that the majority of the women in the survey reported having abdominal pain as the most common symptom, then bloating, followed by diarrhea. Interestingly as well, more than half of these women who experienced the symptoms during the postpartum reported having a gluten exposure. We have an ongoing multi-center observational study at our center called the Preg Study. Again, this is a multi-center, so it's basically national, and you can also go into any site at Massachusetts. But the main objective would be to determine the frequency of gastrointestinal and extraintestinal symptoms in postpartum patients with an established celiac disease diagnosis. And who can participate in this study? Well, we have three main subjects. First off, women with celiac disease who are currently pregnant, followed by women with celiac disease who are not pregnant, and then healthy pregnant women with no celiac disease can also be part of the study. A very plus point from this study is that the subjects will be able to enroll in the entire study remotely. So you won't have to come into visits as usual, for example, in other studies. You can do it all from the commodity of your house. You would have to do some online surveys at established time periods and also do some stool collection, which we would also ship the stool collection kits to your house. In summary, celiac disease is associated with delayed menarche. What do I mean by menarche? Menarche is the first menstruation a woman has, so this period would be delayed. And also, celiac disease is associated with earlier menopause, therefore shortened reproductive life. There's an increased prevalence of celiac disease in those with unexplained infertility. However, due to the recent studies, this may not be the case anymore. It is also associated to nutritional deficiencies such as zinc, folic acid, iron, and selenium. And celiac disease is also has an increased risk of having a low birth weight in your baby or preterm birth. Also, persistent iron deficiency anemia is common, and diarrhea should prompt testing for celiac disease. There's also an increased risk of miscarriage. So to finalize, just some key points to support a healthy pregnancy when you have celiac disease. First off, try to avoid stress and anxiety. Keep in mind that a woman following a gluten-free diet may not be at an increased risk for complications. Second, be as strict as possible on the gluten-free diet. Again, this is your favorite ally. Three, you can take some standard prenatal multivitamin labeled gluten-free. And also, we would recommend going into a prenatal nutrition consult with a celiac disease registered dietitian to cover all bases of healthy nutrition for pregnancy, including but not limited to macronutrients, as well as calcium, vitamin D, iron, B12, and other B vitamins. So thank you very much. And again, in case you need any other kind of information regarding the Preg study or also celiac disease and reproductive health, you can contact us at cdpreg@bidmc.harvard.edu.
Thank you so much, Dr. Banegas. That was great. Don't forget to submit your questions into the Q&A feature as I move forward. I'm now going to invite Dr. Maureen Leonard to share her slides as I introduce her. Dr. Maureen Leonard is the clinical director of the Center for Celiac Research and Treatment at Mass General Hospital for Children and an assistant professor of pediatrics at Harvard Medical School. She sees adult and pediatric patients with celiac disease, non-celiac gluten sensitivity, and other gluten-related disorders. Dr. Leonard's research is focused on predicting and preventing celiac disease through the NIH-funded Celiac Disease Genomic Environment, Microbiome, and Metabolomic, sorry, I always say that wrong, study. Dr. Leonard's other work includes identifying biomarkers that can predict intestinal healing in pediatric patients with celiac disease, building translational models capable of predicting autoimmune disease in high-risk individuals, and working with industry collaborators to create and perform clinical trials aimed at treating celiac disease. Welcome, Dr. Leonard.
Thank you, Dasha. We'll just say CDGEM from here on out too. So I want to just thank everyone for the invitation to participate in this webinar on celiac disease and reproductive health. I am a pediatric gastroenterologist, so I will really be focused on sort of the infant and can address questions around that. I will show my disclosures, which are related to monitoring adherence to the gluten-free diet and alternative treatments to the gluten-free diet, but they're not in conflict with what I'll speak about today. And so the objectives for my talk are to review factors that may contribute to celiac disease onset. And specifically, I'll focus on genetics and gluten introduction in infancy. I will describe our prospective cohort, a study of infants at risk of celiac disease called the CDGEM study. And I'll briefly introduce our approach to the future of predicting celiac disease onset. And before I start, I also have sort of a poll question that I want to put up there. So this question is, when is the best time to introduce gluten into an infant's diet? And the possible answers are 0 to 3 months, 4 months or older, 12 months or older, or never. So you'll have a couple of minutes to answer this question, and we'll come back to the results in a little bit. So this group is well aware that celiac disease is incredibly common. It affects 1 in 100 people, and data suggests that over the past 50 years that the incidence of celiac disease has been rising, along with other autoimmune conditions like multiple sclerosis, Crohn's disease, and type 1 diabetes. Recent studies have also found that the incidence of celiac disease is increasing, with one study finding a 4-fold increase in incidence over a 20-year period in the UK, and a study from the Mayo Group finding a nearly 3-fold incidence over a 12-year period in children. So based on this data, the incidence and prevalence of celiac disease is expected to continue to rise. And yet the associated genes, which are the HLA DQ2 and DQ8, and the trigger gluten have not changed. Up to 40% of the population carries the compatible genes to develop celiac disease, and most of them are eating gluten, and yet only 2 to 3% will develop celiac disease in their lifetime. So having the compatible genes and eating gluten are necessary, but not sufficient to develop celiac disease. And work focused on these areas, so specifically genetics and timing of gluten introduction into an infant's diet, have really provided some important insights into celiac disease pathogenesis. So previous work from prospective studies that followed infants from birth have shown that the HLA genetic type is the strongest known predictor of celiac disease onset in children. Together, 3 studies followed thousands of children with the right genes to develop celiac disease and a first-degree family member with celiac disease, and found that 19% of children with a standard risk gene, so 1 copy of HLA-DQ2 or DQ8, and up to 38% of children with the highest risk genes, so that's 2 copies of HLA-DQ2.5, developed celiac disease by age 8, again, when followed from birth. So this is much, much higher than we see in the general population. And then in addition to genetics, there's been an appropriate focus on how and when gluten is introduced into an infant's diet. And the data and recommendations around this have been conflicting and incomplete. But before we go into this data, let's take a look at what our poll showed about sort of the best time or the right time to introduce gluten into an infant's diet. Okay, so we have 65% say 4 months or older, and 34% said 12 months or older. So this is great. Few said 0 to 3 months, and few said never. So we're going to go through the data now. So some of the initial work and initial focus in this area centered around Sweden in the period between 1984 to 1996. And during this period, there was a 4-fold increase in clinically detected celiac disease in children under 2. And this was later linked to changes in feeding recommendations, which included early introduction and an increased amount of gluten, which was found in industrial produced foods formula, essentially given to infants. So this finding was really important for a couple of reasons, including it suggested that there were, for celiac disease, modifiable environmental risk factors that really center around gluten introduction. Later on, there were some case control studies and meta-analyses that supported these findings and linked the decreased length of breastfeeding, introduction of gluten once breastfeeding had stopped, and the timing of gluten introduction to an increased risk of celiac disease. So based on all of this work, prospective studies were conducted to really delve into the timing of gluten introduction in the first year after birth. So there were 2 studies that were both published in 2014. So the first looked at the timing of gluten introduction, and they had 2 groups. In the first group, they introduced gluten, what they called early at 6 months, and the second group was introduced to gluten later at 12 months. And what they found was that in both groups, the early and the late, that by age 5, the same number of children had developed celiac disease autoimmunity. The second study examined whether introducing small amounts of gluten between 4 to 6 months of age altered who developed celiac disease, with the thinking that maybe it would protect them against celiac disease. So in this study, again, one group had small amounts of gluten between 4 to 6 months of age, and the other group did not. And again, by age 5, the same number had developed celiac disease autoimmunity. So these studies showed that celiac disease onset really was not associated with the timing of gluten introduction in the first year, or at least this 4 to 6 month time period in one case, or 6 and 12 months in the other. And this work ultimately led to a change in recommendations in feeding practices. So we will get to those a little bit later, but these studies also looked at whether birth delivery mode or amount of time breastfeeding was associated with risk of developing celiac disease. And again, against what previous studies had found, These studies did not find any increased risk of celiac disease in children born via C-section, and they didn't find any protective effect for children who were breastfed. But while there's really solid data looking at timing of gluten introduction in the first year, there's limited data regarding the amount of gluten consumed early in childhood and the risk of celiac disease onset. And there have been 2 recent studies that have been addressing this. So the first is a prospective study that used 3-day diet history to estimate gluten intake and found that celiac disease onset was increased if a child ate more gluten. So they found if a child, celiac disease autoimmunity was increased if a child consumed greater than 2 grams of gluten per day at 2 years, and that the risk increased for every 1 gram per day eaten beyond this. So this study suggested overall that increased gluten intake is associated with an increased risk of celiac disease. However, a second study looked at amount of gluten introduced between 4 and 6 months of age as part of a larger study looking at food allergy. And in this study, there were 2 groups. There was a standard group, which was recommended to ingest no wheat before 6 months of age. And then there was an early introduction group, which was recommended to receive 4 grams of gluten per week during the same time period. So starting at 4 months. And there was some concern that maybe giving this much gluten early on would lead to an increased risk of celiac disease. But what they found was the opposite was true, that it was 7 children in the standard group compared to no children in the early intro group developed celiac disease. Now, this study was done for other reasons. This was a secondary analysis. And when they looked into the data, they found that actually 40% of the children in the standard group were eating gluten, even though they weren't supposed to be. And the early intro group of 90% were eating gluten, but the majority were not eating as much as they were recommended to eat or as consistently as they were recommended to. So this makes it hard to draw conclusions from this study. And it really suggests to me that we do need randomized placebo-controlled trials to investigate this further. So these studies have led to sort of evolving recommendations about when to introduce gluten into an infant's diet. So in 2008, most of these recommendations come from either the European gastroenterology group, and the last are from both the European and the North American group. But in 2008, based on data from what happened in Sweden and these case control studies, the thought was that breastfeeding was protective and that it was best to introduce gluten between 4 to 6 months of age. However, after the publication of those 2 studies that we reviewed in 2014, the recommendations were updated to say breastfeeding is not protective. This 4 to 6 month period is not a protective window period either. And there was, a recommendation against large amounts of gluten in the first months after gluten introduction. Finally, today, there's agreement that introducing gluten at less than 3 months of age may increase the risk of celiac disease. And again, that comes from what happened in Sweden in the 1980s and 90s, and that there's no window period safe for introduction. So any time after at or after 4 months is deemed safe. But it's still unclear, what to make about how much gluten to introduce. So these studies have told us so much about the genetics and introduction to gluten. And we know that these 2 things are incredibly important in the development of celiac disease. But there have to be other factors as well. And the rapid sort of increase in incidence that we saw suggests that environmental factors may be playing a role in the development of celiac disease. There's factors such as viral exposure, antibiotics, other household factors that can all possibly influence the development of celiac disease. And these environmental factors are also known to influence the microbiome, or the collection of microorganisms that live in the gut. alterations in the intestinal microbiome or the gut microbiome have been linked to autoimmune conditions, including celiac disease. So given these factors and how much we have to learn about the early factors that might trigger celiac disease onset, we aim to develop a prospective birth cohort of infants at risk of celiac disease in order to take an approach to try to put it all together and learn if we can predict celiac disease onset. So we developed the CD-GEM study. It's an international observational study, and the goal is to sort of investigate the role of the microbiome and the metabolites that they produce as a factor that might be involved in the pathogenesis of celiac disease. And we recruit pregnant mothers and infants with a first-degree family member with celiac disease and follow them for 5 years. So this study is still ongoing and recruiting, but we have recruited 500 infants at risk of celiac disease who are less than 6 months of age. And the majority of half of the infants are from the United States and the other half are from Italy. And from these 500 infants, we're on track to have 400 complete the study. And since they have a family member with celiac disease, we expect about 75% of them to have the right genes to develop celiac disease. And that during the course of this study, up to 15%, so up to 50 children may develop celiac disease. We make every effort to enroll infants prior to birth. That allows us to collect maternal prenatal stool, cord blood, maternal and infant stool, and breast milk 1 week after birth. We then collect stool every 3 months and blood every 6 months to test for celiac disease. And then we collect a lot of clinical information monthly to learn about what foods are being introduced, when gluten is being introduced, how much. We learn about antibiotic exposure, probiotic exposure, and then we have other questionnaires every 3 to 6 months that ask lots about household environment. And despite there being a lot of samples to collect, we have a very amazing celiac disease patient community, and we've met our recruitment goal and expected retention rate. And so while the study is still ongoing, and we're watching these children grow, the average age in our cohort is about age 3. And we have thousands and thousands of stool samples and even more data points to start to analyze. More than half of the mothers in our cohort have celiac disease. And again, while our cohort is quite young, we already have over 30 children that have developed celiac disease. And like we've seen in previous prospective studies, when we're looking for celiac disease, we do find it quite early in this at-risk group. So 75% of those that have been diagnosed in our prospective study have been diagnosed by age 3. And so I want to briefly mention some of the research that we've been doing. So we published a manuscript aimed at investigating whether underlying genetics in combination with early environmental risk factors, which we define for the purposes of this research, was C-section delivery, formula feeding, and antibiotic exposure. So we wanted to see whether these factors altered the composition of the gut microbiota in infants at risk of celiac disease. And so we did this by looking at stool samples that we collected between 0 and 6 months of age. So even before the infants were introduced to gluten. And when we did this, we were able to identify changes in the microbiome in infants exposed to C-section delivery, formula feeding, and antibiotics that we could link to, in previous research, autoimmune conditions and impaired immunity. In the non-exposed infants, so our control group was infants that were born vaginally, who were strictly breastfed, and who were not exposed to antibiotics. And our analysis showed that there we identified changes in the microbiome that have been previously linked to anti-inflammatory effects. So this told us we could actually see some changes in the microbiome, again, even before gluten was introduced. But because we only followed them between 0 and 6 months, we couldn't link any of these changes in the microbiome to celiac disease onset. So our next step was sort of to address that limitation and examine the trajectory of the gut microbiome in children prior to celiac disease onset. So briefly, from the 500 enrolled subjects, we selected the first 10 that developed celiac disease, and then we selected 10 matched controls for the analysis. And we were able to match them according to the date of birth to account for the season of birth, the country or region of origin, their genetic type, gender, birth delivery mode, time of gluten introduction, and time of solid food introduction. And we wanted to take all of these into account in an effort to minimize the effects on the microbiome. So hopefully anything we saw we could link to celiac disease onset. We then performed an analysis on stool samples from these subjects, and we were able to look at sort of the time that the cases developed celiac disease compared to controls, as well as a longitudinal analysis looking at all the time points from birth to onset of celiac disease to see what changes were happening as they moved towards developing celiac disease. And our cross-sectional study, so our study just looking at one time point when the child developed celiac disease compared to controls, didn't identify too many findings, but our longitudinal analysis did. So in cases, we were able to identify changes in the microbiome, again, linked to autoimmune and inflammatory patterns, so an increased abundance of microbes linked to these things, and a decreased abundance of microbes, pathways, and metabolites previously reported as probiotics or having anti-inflammatory properties. And we were also able to identify unreported changes in the microbiome that might serve as celiac disease specific biomarkers and that we need to look more into. In our controls, so our patients that didn't develop celiac disease, we did find changes in the microbiome as well, but these ones were linked to protection against allergic, autoimmune, and inflammatory conditions. So a lot more work to be done, but we have some hints and now more cases of celiac disease and more controls to examine. So through this cohort, we've also had a chance to start to look at breast milk and examine. We've started with examining the microbiome of breast milk in mothers with celiac disease on a gluten-free diet compared to mothers without celiac disease on a regular diet. And overall, we found some minor differences in the abundance of certain bacteria and certain viral strains. But in looking at it, the breast milk appears quite similar between subjects with celiac disease on a gluten-free diet and healthy controls. And that brings up a question I know that I've been asked in clinic, which is, can gluten be transferred through breast milk? So there's very limited data looking at this, but it might come up if a child is diagnosed with celiac disease and is still being breastfed. So we know that dietary antigens are secreted in the milk. There's a study from 1998, so older, and I'm sure there are newer technologies that hopefully we can look into and try and answer this question. But from the information we have, gliadin, which is one of the proteins in gluten, is able to be, we can detect it in breast milk. There's a wide variability between subjects or mothers or the breast milk. But overall, from the information we have, it's a very small amount. So if you were to do the calculation out, it would be less than 20 parts per million. So the answer is yes, gliadin can be transferred through breast milk, but the concentration is less than 20 parts per million, at least according to this work, and therefore we should consider it gluten-free. So finally, that's another piece that we're able to gain from this cohort, and we have, as I said, a lot more work to do, but the goal is to try and put sort of lots of information together to figure out if we can someday predict celiac disease and then develop therapeutics to treat celiac disease and ultimately prevent it. So someday, instead of waiting for patients to develop signs or symptoms, we may have preventative visits where we can combine sort of what we know about their genome and add that together with what we know about their environmental exposures, add that to what we can learn from their stool, looking at their microbiome, and finally put it all together to try and sort of identify when some people are heading towards celiac disease, and then engineer pre or probiotics or special diets to try and help keep them healthy. So to wrap up, introduction of gluten should occur after 4 months of age, even with patients at the highest risk due to family history. We recommend testing high-risk children, or we recommend testing children with a family history of celiac disease starting at age 3, and then every couple of years after that, at least every 3 years or every 1 to 3 years. Data regarding the amount of gluten to introduce is still conflicting. And the amount of gliadin transferred in breast milk varies widely, but is less than 20 parts per million. And hopefully we can sort of combine all of our work studying, pregnant women with celiac disease and children at risk for celiac disease to learn how to prevent and treat celiac disease. So we are still enrolling. Our study is still open, and we have a website, which is cdgem.org. And then I'd like to thank all of the children and families in our study, as well as our research group at MGH in Italy, our collaborators, and everyone who has donated to help this research go. So thank you.
Thank you so much, Dr. Leonard and Dr. Banegas. I appreciate all the questions that people are putting into the question and answer portion. You can feel free to continue to add those. I'm now, as we move over into the question and answer portion, it's my pleasure to bring in Amelie Therrien into the discussion. She received her MD in 2011 from the Université de Montréal and completed her internal medicine residency and then her adult GI fellowship, combined with a clinical scientist program in 2017. She is a fellow of the Royal College of Physicians of Canada in internal medicine, adult gastroenterology, and clinical scientist. She completed a master's degree in experimental medicine with a focus on immunology, working on Crohn's disease in 2018, and moved to Boston to study celiac disease with Dr. Kieran Kelly and the Celiac Research Program at Harvard Medical School. Her main areas of expertise are celiac disease, other small bowel disorders, nutrition, inflammatory bowel diseases. She is now working as a clinician scientist at the Celiac Center at Beth Israel Deaconess Medical Center and as an instructor in medicine at Harvard Medical School. So let's move into some of these great questions that we have. I'm going to kind of divide them up into general categories. We have a number of questions on how a woman with known celiac disease can prepare for pregnancy. And this was touched on some in the presentation, so there may be a little bit of overlap. One question we have is, should a woman with recently diagnosed celiac disease consider waiting until she has negative antibodies before trying to conceive? Or if not negative, how low is safe?
Yes, so that is a great question for which we do not have a strong answer. Theoretically, it will be best to have negative serologies, but we know that unfortunately it can take more than a year in some cases to fully normalize, especially if someone starts with a TTG higher that is very high. So I know that it can put some women in a difficult spot, waiting to have their serology normalized versus having their fertility naturally decline with time, especially if they are older than 35 years old. So there are no studies looking specifically at the risk among women following a gluten-free diet, but with still positive TTG. Marcela showed you the data about still having like abnormal biopsies, but being on a gluten-free diet. And that was reassuring in terms of like pregnancy risk. So I think that in general, if the woman has been on a gluten-free diet for more than a year with otherwise normal blood work, no symptoms, with a strong like dietitian, like consultation and follow up with gastroenterology, it could be overall reassuring to try to conceive depending on your timeline.
Maybe now's a good time to ask another question specifically about TTG and if TTG accurately detects exposure to wheat and rye and barley, and how accurate is TTG in predicting exposure and intestinal healing?
Yes. So what is TTG? So TTG is an enzyme in your intestine that kind of like process the gluten that is absorbed. So the immune system in celiac disease produce antibodies against that enzymes and the gluten that is bound to it. To produce antibodies, you need to have like chronic exposures. To have like one slice of bread once and having overall a gluten-free diet will not necessarily increase your TTG. You need to have about like 2 weeks of relatively daily exposures to then eventually have positive serologies. And so the TTG, it's not an antibody against the specific like wheat or rye or secalin. It's an antibody against the enzyme that is bound to the gluten. There are some tests on the market that detects like the gluten in the urine and in the stools to see if you have had the recent exposures. These tests are commercially available. They are not like currently recommended by guidelines in celiac disease for their use in clinical care, but we'll see in the upcoming guidelines if they become recommended.
Great. Another question along these same lines is are there other tests or specific actions that a woman with known celiac disease might want to do before becoming pregnant?
Yes. So I do not, I'm not a fertility specialist. So to assess the fertility in general, it will be best to go with the gynecologist. But on the side of celiac, we check the serologies. We perform a nutritional panel. Like Dr. Banegas mentioned, we are looking for the iron stores, the folate, the B12, the zinc. Take a prenatal vitamin as soon as you are thinking about conceiving. It's important to have like good amount of folate months before the conception, and have a consult with a celiac dietitian who will make sure that nutritionally you're getting like enough of your micro and macronutrients. I'm sorry.
Excellent. And this kind of, I think you just answered this next question, but it came up that many of the gluten-free replacement products are not fortified. And the question specifically is this a problem for women with well-controlled celiac disease not getting adequate nutrition from gluten-free foods that they eat during pregnancy? And I guess the question is the multivitamin that you just discussed enough to cover that need?
Yes, I think it's on a case-by-case basis. We should definitely do like blood work to reassess the nutritional status, reassess like how long has the woman had celiac disease, and also work with a dietitian to make sure that in addition to the multivitamin, the diet is in general diverse enough in like the overall nutrients, independently of the fact that the gluten-free products are not fortified.
Excellent, thank you. We also got a number of questions focused specifically on infertility, and I do recognize you're not a fertility specialist and come here with your celiac disease specialist hat on, but I'm going to go ahead and ask to see if you have any insight. So based on the presentation, we know that celiac disease is implicated in unexplained infertility. But is there any data on celiac disease and how it relates to specific causes of infertility in women, specifically like low egg quality or endometriosis or pelvic adhesions were some of the questions that were asked?
Yes. So we need to think about egg quality. It's linked to ovarian reserve, like the amount of eggs that we have in our ovaries. So there are some sex hormones, FSH, LH, that are naturally secreted and contributes to like the menstrual cycle, the menarche. And we know that in celiac disease, to have first like malnutrition and vitamin deficiencies can kind of like shift the body towards a more like survival state, and the sex hormones are less produced or are less efficient. So it means that the woman may have like irregular menses, can have like a delayed menarche. So depending on how long the disease was present and undiagnosed, it may mean that the woman did not start with the same amount of eggs than other women, and they can have an earlier menopause. However, data from Italy showed that if you are on a gluten-free diet for at least like 10 years before the regular time of the menopause, so let's say in your 30s, it kind of like leads you to have a menopause that is about like the same time as a woman who would not have celiac disease. About pelvic adhesion, I didn't find anything like regarding that, but interestingly, there is an association between untreated celiac disease and endometriosis with a small like excess risk. But usually this endometriosis is diagnosed at the same time of the diagnosis of celiac disease, and it's less likely to suddenly diagnose endometriosis like 5 years after a diagnosis of celiac disease, meaning that if you have like well-controlled celiac disease, it is unlikely that you will eventually develop endometriosis. It's more like if you have like active celiac disease, chronic inflammation, it could, in a small risk, predispose you to have endometriosis. There is also a common like genetic factor between the two conditions, interestingly.
That is interesting. In couples who have unexplained infertility, this is a question we got, is it worth trying a gluten-free diet for either the woman or for a man with unexplained infertility?
So first, someone should always be tested for celiac disease prior to start a gluten-free diet. The blood work is available with your provider. And I got a nice comment from the chat during Dr. Banegas presentation about like total IgA, because it's true that in our presentation we mentioned like the TTG at large, but for a first-time blood work we need to see if the person has enough like antibodies in general, because some people can be IgA deficient with celiac disease, meaning that they will not produce like TTG IgA like others. So we first need to check also if the person is able to produce the IgA. So we first do the blood work to make sure that the person doesn't have like undiagnosed celiac disease prior to start a gluten-free diet. And in some instance, if there are other symptoms, we will still do an upper endoscopy, even if the blood work is normal, and duodenal biopsies. Second, without celiac disease, gluten exposure should not have an impact on the fertility. So gluten is not digested and mostly not absorbed by the GI tract. So to go on a gluten-free diet or another like restrictive diet, such as low sugar, could have a negative nutritional impact on both your fertility and healthy pregnancy. And for men, yes, if they have celiac disease, to follow a gluten-free diet may improve their fertility and their sperm count. But if they do not have celiac disease, I didn't find like a benefit of like going gluten-free.
Thank you. I wanted to ask a little bit about miscarriage. You know, Dr. Banegas mentioned in the presentation about the risk of untreated celiac disease and adverse fetal outcomes like premature birth, and how there was a positive effect on the diagnosis and treatment with a gluten-free diet on reducing those risks, which I thought was really reassuring. The data for miscarriage and untreated celiac disease you talked about as well as being elevated. Is there any data on the risk of miscarriage in treated or managed celiac disease specifically?
Yes, we have data from Sweden. Sweden, with their national registry, they are able to follow their entire populations and see what happened with people. And they saw that in women who had an initial diagnosis of celiac disease and then got pregnant, there were no increased risk of miscarriage compared to the general population. And also with the data from Columbia University and Sweden, also with the women who were still having a little bit of like villus atrophy in their biopsies, but were on a gluten-free diet, following their diet strictly, they also did not have more miscarriages. So this is all overall encouraging for women with celiac disease who are following their diet for at least 1 year.
Excellent. I'm going to shift a little bit and ask some questions now about breastfeeding. And I think this is an area that kind of overlaps a little bit with both you and Dr. Leonard. One of the questions we got was related to thinking about the role of breastfeeding and genetic risk. And the question specifically is if you have a baby with increased genetic risk, for example, a grandparent with celiac disease, but the mother does not have celiac disease, if the non-celiac mother is gluten-free during breastfeeding, would this affect the risk of the celiac disease in the child at all? Maybe this is a better one for Dr. Leonard.
Sure. So that should not affect the risk for the child. So as I said, there's not too many studies looking at sort of the breast milk and the gliadin in the breast milk and how that affects celiac disease risk in the future. But from what we know, not having gluten or eating gluten while breastfeeding is not known to lead to an increased risk of celiac disease.
And along similar lines, with the data that we have, do you still generally recommend breastfeeding for babies that are high risk of developing celiac disease?
Yeah. So as a pediatrician, we didn't talk about it, but we recommend breastfeeding when possible. In addition, there's multiple good things, immunoglobulins and so many things that come with the breast milk. So we would recommend that when possible. And if not possible, then formula is great too.
Right. Fed is best, right?
Exactly.
And this might be another one for you, Amelie, to weigh in on. Is there any research specifically regarding breastfeeding in untreated celiac disease? And I think this question may be getting at, risks of breastfeeding, concerns for the mom of breastfeeding with untreated celiac disease. I'm just interested if there's any research along those lines that you've come across.
On my side, no. I don't know if Dr. Leonard has some insight.
No, there's no research that I know of, and it sort of came up when we were looking at the microbiome of mothers with celiac disease on a gluten-free diet and comparing that to mothers without celiac disease on an unrestricted diet to say, I wonder what would things look like if we did have mothers with undiagnosed, or untreated celiac disease. But again, I'm not sure that study can be done because I think as soon as we'd find it, we'd want to help that person, get on a gluten-free diet to make sure that they're absorbing all the nutrients they need for themselves and to feed their baby. So I think that would be a hard study to do.
Agreed. I'm going to ask a few questions now about sort of the postpartum period, or even during pregnancy and symptoms that women with celiac disease may get. There was a question that you answered in the question and answer feature, but I wanted to kind of touch on it, which was talking about, the immune system and how it's suppressed during pregnancy to prevent, to allow for the pregnancy to be successful. But that sometimes it can ramp up postpartum and cause sort of hypersensitivity, even though gluten isn't actively being consumed. I wondered if you could speak a little bit about that thought, that concept.
Yes, so we know that in general, because celiac disease is part of a group of disease that are autoimmune, like let's say Th1. So it's a certain type of immunity that acts on the body, and we know that this immunity usually like goes better in the first part of the pregnancy, because it's all part of like the tolerance, like tolerating the baby. And then towards the end of the pregnancy, there is kind of a drop of the sex hormone, the estrogen, the progesterone, and there is also an increase of the prolactin. Prolactin is like the hormones that allows you to produce milk and breastfeed. And it has been shown that the immune system could be a little bit triggered by these changes in the hormones, especially the prolactin. And then either like towards the end of the pregnancy or during the postpartum period, it can be a little bit more reactive. Could it be reactive without gluten exposure? We are not sure about that. Until recently, we didn't have a good way to assess whether or not the person was exposed to gluten. It was only like dietary recall. But now with the stools and the urine tests that we can do to look for gluten exposure, we can detect like unsuspected gluten exposure. And we know that in the postpartum period, things are crazy. The family may bring some food for the mother, the family. So could there be some extra contamination that in general before the woman was tolerating well? But now, because of the hormonal fluctuation, she's a little bit more reactive to a small amount of gluten. So this is why in our study, CD-Preg, we added the component of having some stool collection, because we will check the stools for gluten to see if in the end, like the women are exposed.
That's excellent. Thank you. And that, I think that is in part answering another question that came up, which was, how do you know if the root cause of symptoms are from celiac disease or from just normal pregnancy and postpartum symptoms that happen normally? I think that's a really great question.
Yes, we know that progesterone has a major impact on the motility of the GI tract, and also the sphincters, like the between the esophagus and the stomach. Some women have more like reflux, constipation, and then with the delivery, there could be some tear, some trauma during. So we know that in general there are some symptoms that naturally comes with the pregnancy and having had a vaginal delivery. So this is why we have a control group. This is why we are looking for women also who are pregnant but do not have celiac disease, to compare like what are their symptoms and what are the symptoms of the woman pregnant and with celiac disease.
I'm going to switch gears over to Dr. Leonard again and ask some specific infant and infant-related questions. There were a number of questions about testing of high-risk infants, specifically asking how early can an infant be tested for celiac disease, and how early can HLA genetics be tested? And a specific question is, can this be done in utero?
Sure. So great questions. So the earliest I know that we can do the HLA genetics is on the cord blood. We do that as part of our CDGEM study. So you can do that at any point, but the earliest is the cord blood. In general, in practice, we don't always recommend getting the HLA genetics for a couple of reasons. One is that they are expensive and insurance usually does not cover it. Two is if you come from a high-risk family, so there's celiac disease in a first-degree relative, that there's a high chance that the child will carry one or both of the celiac genes. So it's probably 75% chance. So again, now we have an uncovered expensive test, and we have a good idea that 75% of the time the child is going to have one of the genes. And then, as I mentioned, even in the general population, 40% have the right genes and 2% go on to develop celiac disease. So it's very low. Or even I was just typing an answer in our children that have the highest risk, so a family member and 2 copies of HLA-DQ2. Even 62% of them will not develop celiac disease in the first 10 years. So it could, you might have worry, but it doesn't tell us that the child will go on to develop celiac disease. So in general, we don't use it too much in clinical practice. What we do is you test for celiac disease. So again, starting with an IgA level the first time and then going forward with an IgA TTG. In my practice, we generally say, start around age 3, unless there are symptoms that are concerning. And then we can test every 1 to 3 years. Again, if there are signs or symptoms that are concerning, like weight loss, slower growth, abdominal pain, diarrhea, constipation, fatigue, all of those things, you might want to get the testing sooner. But it's important to check, early, and then important to check again every couple of years, but particularly before a child starts puberty, because we want to make sure that we can address it and treat it before they are, well on their way through puberty, to make sure that they maximize their growth.
I say the same thing on my side of my practice as well. And that kind of talking about puberty brings me to another question that somebody brought up in the Q&A, which is related to the delayed menarche that we see in patients sometimes with celiac disease, and specifically wondering if that phenomenon contributed to incomplete breast development or insufficient glandular tissue in women with celiac disease. This is perhaps out of our specialty area, but I wondered if either of you had any thoughts about that.
I will say no.
Yeah.
No, on my part, I'm sorry.
Yeah,
I wanted to mirror to Leonard, but to Dr. Leonard, but no.
I was thinking about this too with my general pediatrician hat, and I think that I'm not sure we understand enough about insufficient glandular growth to know if that's a factor. And I always think of sort of delayed puberty and delayed menarche as something that can affect growth, but not so much long-term breast. It's a delay of, not an impedance of. But it's a great question. I think maybe we could learn more about that. Just going to quickly look to see if I've hit the highlights. We're getting awfully close to the end of our session. I think that has done a number of. Let me just quickly scan what we've got in here and see if there's any other big topics that I've missed. There's a question here. Do you change asymptomatic testing frequency after puberty? We talked about the importance of before puberty, but what about after puberty?
I think it's okay to, at that point, kind of become a little bit more lax about testing. So we still want to do repeat testing, but again, every maybe 1 to 5 years at that point. Or I usually say if you're getting blood tests for another reason, you can, put a TTG in there, but I wouldn't recommend an extra visit for it.
And I think the last question is for you again, Dr. Leonard. And if you could just review what we know about infant feeding and what we know now about when to introduce gluten. I know you covered that in your talk, but just to kind of review it again, because we got some questions about that. And then also to expand it, is there any other specific foods that you would recommend introducing differently to a baby at high risk of celiac disease?
Sure. So I think what we know is that breastfeeding is not protective against celiac disease, but there are lots of other factors for breastfeeding that make it good. So if that's a possibility for you, then that's great. In terms of timing to introduce gluten, I would say at any time after 4 months. We don't want to do it before then because of the data that we reviewed from Sweden. But any time after 4 months would be fine. There's nothing known about, introducing it later and increased risk of celiac disease. And finally, we still have a lot more to learn about the amount of gluten. So we don't have sort of recommendations regarding the amount of gluten, but anytime after 4 months is okay. The American Academy of Pediatrics suggests sort of breastfeeding until 6 months of age, and then the introduction of foods. So I know people do things differently. I have a little one, and I started closer to 4 months, and that's recommended as well. Once they're sort of ready, they're showing the signs for feeding, then they're ready to go. So I would say, I paid particular attention to sort of the allergen foods, and I wanted to introduce those early. I was worried about celiac disease, and my little one developed a nut allergy. So, it's what you don't expect, and you can follow all the things, and, you can't control everything. So that's what I would say, talk to your pediatrician, but anytime between 4 and 6 months is a fine time to start introducing foods.
Thank you. That's great. I'm going to wrap up the question and answer session. Thank you so much to our presenters and to Dr. Therrien for her participation in the question and answers. And I'm going to pass it on to Lee Graham. Thanks, everybody. And thanks for the great questions from the audience. That was great.
Thank you, everybody. Oh, you doctors are just amazing. My head's full of all sorts of information. It's going to take me a while to go through it all, but thank you for your time. Stay tuned for our March 23rd webinar, Living with COVID-19, Celiac Disease, Autoimmunity, and Hyperinflammation. It is going to answer questions like, will the pandemic ever end? And what are the long-term effects, if any, for someone living with celiac disease or other autoimmune disorders? And what COVID-19 treatments are safe for people with celiac disease? And are all masks safe for people with gluten-related disorders? Until then, from all of us here, thank you, and we'll see you next time. Bye-bye.